Whether you're a parent navigating myofunctional disorders or simply curious about optimizing your family's overall health, the MyoHacker Podcast is your guide. Hi, I'm Karindy Ong, a speech-language pathologist, myofunctional therapist, and a mom on a mission to bring holistic health to you and your family. Together, we'll explore whole-body connections and integrative solutions. Please subscribe and leave us a 5-star review to help other families discover this important information. Visit MyoHackerSLP.com for free resources and guides. Quick disclaimer. The content shared in this podcast is for information and entertainment purposes only. The views and opinions expressed by the host and guests do not necessarily reflect those of the podcast or its affiliates. This podcast does not provide medical, legal, or professional advice. Always consult a professional regarding your circumstances. By listening, you agree that the host and podcast are not responsible for any actions you may take based on the information provided. Now, let's dive into today's episode. All right, everyone, I am so excited about this next guest of the MyoHacker Podcast. Joining us today is my dear friend, Amy Luedemann. She is a pediatric dentist who has been a game changer in the world of laser dentistry and in incorporating the ALF, which we will talk about a lot today in this podcast interview. So I just want to open this up and say, Amy, can you give a little bit of an introduction about yourself? And then we're going to dive into the questions that I have for us.
Sure. Thanks for having me. I'm so excited to be here and be a part of spreading the word about ALF. My name's Amy, and I have been in dentistry since 1990. I started as a dental assistant and was an assistant for 11 years, and then went to dental school and pediatric residency. And recently, I just stepped away from my practice and am doing new things. One of those new things is something I'm super excited about, because in the greater Houston area, there are just so many people and weren't very many ALF providers. Really just me and one other who's learning, and then hardly any across the state of Texas. So I'm moving into the world of consulting, and I'm really excited about that because I go one-on-one. So we spend a little time on Zoom first, then I go one-on-one to their practice with their patients and help them because I have a lot of material. So I just meet them where they are and see how I can assist them in getting really comfortable and excited about providing ALF for their patients. So I'm doing that along with some other non-dental stuff on the side. It's also very exciting.
So I should also add that Amy is a biohacker, which it was so fun. When we first met, actually, this is a funny story. Okay, guys. So I'll just say, when we first met, I was like, oh, Amy, you're a biohacker. She was like, what's that? And sure enough, she definitely is one. So that means she's optimizing her health and really using new technologies and methods to optimize the health of her patients, which I just have loved. But when we first met, I was working in a clinic and I kept hearing everyone talking about Amy Luedemann and the different appliances and devices she was doing in these treatments. And I was like, guys, who is this? What is happening? Like, I kept trying to get more information. And finally, I was like, I think I just need to talk to her because I need to understand this more. So I scheduled a call. Little did I know that I was going to get a terrible frenectomy the day before our call. And that's its own story. This guy's, you know me, I have to dive in to learn things. And I got a frenectomy way before I was ready for one. And when I was newly learning airway things, I thought I knew what I was doing. I did not. And so we end up on this Zoom call the day after I've had this release from a provider who did a terrible job. The laser literally died midway through my tongue tie release. And so I felt the second half of it, like the right side. Anyways, it was a mess. So I, the next day, get on this Zoom call with Amy and we are sitting there talking and I have to just tell her, I'm like, I'm so sorry. My articulation is terrible today because I had a tongue tie release yesterday. And she's like, oh, let me see. And I lift my tongue and she's like, that looks so painful. That looks terrible. You need to come in today. And we did like biostimulation and then laughter. And she set me up with incredible things that took the pain away because I truly was in a lot of pain. And that really set the stage for, I think, just as practitioners, how we would intervene together and then become friends. So guys, now you know the background about Amy and I. I want us to jump into some questions about the ALF. Actually, let's first ask this question. Okay, so the ALF has been a part of your progression and your growth as a dentist and a provider, but I want to know how you changed your perspective from being a drill and fill dentist who just, really has sort of that traditional approach to being a trailblazer and being someone who is changing the way dentistry is done and seeing things really from a more holistic, whole body approach. So let us know a little bit about that.
Thank you. I will. Yeah. I want to say that was a really fun Zoom call, the first call with you, and it definitely was the start of a lot of fun. Yes. Karindy, I don't really feel like I've ever had the drill and fill approach.
There we go.
So I started as like a super phobic dental patient like myself. I probably would have never gone to the dentist if I didn't end up in dentistry because I had such terrible experiences as a kid. And then I wanted to get my first job and I had typing skills. So I applied I circled the ad in the newspaper and applied as a receptionist at the dental office and got the job. And he taught at the dental school. And so he immediately wanted to teach me to be an assistant. And I nearly passed out the first time I saw a shot on a patient, which was for a maxillary frenectomy, by the way.
Wow.
So yeah, that was like in 1990. And yeah, so I really feel like I'm not a person who said, I'm going to be a dentist when I grow up and do all the right things to get on that path. I was someone that was more a calling that, I just kept doing the next thing in my life and God led me towards dentistry, which is if someone had said, what would you definitely not be? It probably would have been a dentist as a kid. So, but what that allowed me is I worked in Dr. Glaros's office in the 90s, who is one of the top biological dentists before anybody really knew what that was. And so I really got to see that perspective in patients healing and learn about, cavitations and all that in the 90s. And then I worked in another amazing office where he became like a dad to me, actually walked me down the aisle. And
wow.
Just the way he treated his team and the way he treated me helped me to grow as a human being. And the way he treated patients. And then I did a lot of contract work. So I worked in a ton of different offices, all the specialties except for endo. And I was really surprised and was kind of afraid. Like, I don't want to be a dental assistant forever because there's a lot of dentists I wouldn't want to work for. It's the way they treated their team or the dentistry that they provided. So it really was all of that stuff. Plus, meanwhile, I always have volunteered with kids on mission trips and abused kids. Since I was 18, I've worked in different capacities with volunteering and stuff for kids. So kids were my passion, but I had worked in a pediatric office that was a pretty typical one with a lot of sedation and restraint. And so I just was like, I'm not going to do that. And then Kathy Flights, who was the dean of the dental school, took me on a mission trip, and that sort of changed everything. I was like, I love people, I love dentistry, and I love kids. And if it can be this way, that's what I'm going to do. And so, again, God just kind of got me into an amazing program that was made just for me, the University of Washington. And it was a very collaborative approach. I really liked the way that the students were treated in residency and the pre-docs and all that. So all of that to say, I don't think I've ever really been a drill and fill. What motivated me, I learned laser dentistry as an associate before I opened my practice. And I was like, why would anybody do anything else? Like, you can do fillings without shots. I really was like, I'm never doing it the other way. And the laser arrived before my practice opened, my first laser. And so our vision was to be the light that transforms lives. And so I just love to learn. I'm passionate about learning, and anything that I could find that made going to the dentist an awesome experience for kids. And I just don't feel judgmental of parents either. I tend to see us as a profession not believing, when they say, oh, we don't eat any candy, but they have cavities. There's like this, doubt. So I just meet people where they are, try to see what I can do to help them, and just constantly was on a path of learning, and anything that seemed like it rang true and that it was helping people, I just brought it into the practice. And that's kind of how, so yeah, it's called an early adopter or trailblazer or whatever, but it was just me following my passion to make things really good for my team and my patients and the families we serve.
Leads us directly into the ALF. When did you, because obviously you saw this is an intervention that is amazing at helping families. So let's discuss this now. What is the ALF? Like, what does it actually stand for? And how did you use it in your practice? And what types of craniofacial changes have you seen? Let's just open that discussion up.
Okay, well, Unfortunately, the ALF has a lot of political drama behind it, and that makes me sad. I've tried to be a part of bringing people together. That's always been something that's important to me. But I have quite a few mentors in the ALF world, and so some of them call it like advanced light forces or advanced light wire, functional appliance, like amazing little whatever. There's all these different names that people have for it. But the gist of the ALF is that it is a light wire. So it's very like flexible and it's very easy and very intuitive, the wire and the resonance of it and the way you work with it. And so, so it goes by a lot of different names depending on who you're talking to. So I think this would be a good spot in the discussion to talk about like the way I would explain it to patients is there's two different approaches, whether you're talking about airway or expansion or, these kinds of things with kids. And one approach is more of an osteopathic approach and non-traditional, and that's where ALF lies, because that approach, osteopathic and ontogeny are two words that I use a lot. And that is really describing that my belief system is that everybody has everything they need inside of themselves from the time of conception to be their best self. And my job as a healthcare provider and as an adult with kids is first to remove obstacles. So a tongue tie might be an obstacle. And secondly, to enrich the environment. Is there something missing, like minerals or any variety of things? So removing obstacles and enriching the environment and then just supporting them through the changes and ideally through function, they get those changes. Whereas the other approach is more of what we do a lot in our society, which is we look at people as providers, we look at patients and we diagnose them. What is wrong with them? And we have all these more and more like fantastic diagnostical, we can look at our heart rate, we can look at our biological age, we can look at our, all these things. And we're just constantly diagnosing what is wrong with someone. And once, you get that diagnosis, okay, great. Now I know what's wrong with me, or now I know what's wrong with my kid. How do I fix them? And so that's a different paradigm. And not that we don't use diagnostics, but then the appliances in this paradigm are forceful appliances. So it's like, I'm looking at you and your palate is too narrow. So I need to expand it. So I'm going to use appliances that I can control the forces. At least I think I can, but every action has an equal and opposite reaction. Although we're not trained to really look for that, where that reaction is happening. But we put forceful appliances in, and now, for better or worse, we not only have forceful appliances that can change the transverse, the wideness of the palate, but we have even more aggressive and powerful appliances where we can push the face forward. But this has negative impacts often on the upper cervicals and other things downstream. But that's kind of the different approach. An ALF appliance is working with the patient to function and get to where their best place is. And it's three-dimensional expansion, and the whole cranium changes in the whole body. Whereas and this is just my opinion, but the other appliances are more of like, I know what's wrong with you and I know how to fix you, and let's get it done. Let's do TADs. Let's do whatever we need to do to make this situation, more structurally the way I think it should be. And that's just a different approach.
What are some of the craziest cases? I don't have this question. I'm just thinking of the craziest cases that came to you after doing other interventions. Like, what are just some examples?
Yeah, I'm thinking of one that was super duper interesting because this girl came in and she had like severe class 2 and huge high palate. I mean, like lower jaw way back there. And she was like pre-teenish, maybe early teens, and into cheer and all this stuff, but like really hard for her to even keep her lips closed and all that. And they came for ALF. And then, there's a lot that goes into it because, right, the team is important, and are we all on the same page and all that kind of stuff. But in her case, she was really severe. And as we started with ALF, the way she was changing was really interesting. The way her palate was shifting with the work of my body worker and stuff, we were noticing, wow, it's peaking first. So we kind of went back through her whole history, and she had palate expansion as a phase 1. Actually, when we looked at her photographs, her face and her palate, as they were doing the expansion, her lower jaw went further back during the expansion. Like, she looked worse after palate expansion from a whole cranial standpoint and a class 2 standpoint. So this doctor was going to put her back in, wanted to do a phase 2 on her, but the mom at that point was like, I don't know. So it was a really interesting case to look at her pre-pictures.
Why do you think, or why did the body worker think, like, what was sort of the consensus as to why the jaw went back?
Well, so we can only guess, right? Mm-hmm. But one thing is that when you put those palate expanders in, she was probably doing some bracing and stabilization with the tongue where she was before. And we took away the tongue's ability to do that. And so then we completely changed function during and had some persistent, pretty poor function afterwards. So basically the jaw, that's just how it responded with how her tongue responded to having that heavy force and that thing up in the roof of her mouth for 9 months or whatever it was. So, and then as we were unraveling in ALF, sometimes you'll see things go back to a similar place to where they were before they start going forward. The other thing to say about it is that I think as dentists, we're not trained and we forget, or we don't even know, like we forget, like this is connected to this. It's connected to everything, but I like to explain it like your head is a 3D puzzle. Right? And so these two little pieces in here, we're talking about the upper and lower jaw. You can't get more oral volume unless you're changing the cranial shape, cranial vault as well, especially in certain cases. So yeah, like you can't, it doesn't work that way. So when we use those heavy forces, we might see some changes here, but we're going to see changes elsewhere too. And in her case, she just got a really severe class 2 in conjunction with expanding her palate. And then she continued to grow with a really poor pattern of function until we saw her. And the sad thing was in that case, we were only in ALF for about 6 months. And then the SLP she was working with started talking to her about surgery. And once they started talking about surgery and going to a surgeon, the little girl was like, she wanted her face fixed. And so I think we only got about a year, maybe a year and some months before the mom allowed the daughter to make that choice. And for me, this is again, just a personal opinion, but the good thing is like, I feel more free to say what I really think in my position. But I think it is outrageous and like a terrible thing that we're doing is sending teenagers and preteens to surgeries. We don't have any data for what that's going to be like in the long term. And we know that if you don't fix function, you have relapse, craniofacially speaking, as well as dentally speaking. And then we're introducing scar tissue into some really important areas of the body. So I just think we really should work hard to do things as minimally invasive as possible. But yeah, I did never get to finish that particular case, but she did make a lot of progress in that time. And then I had another girl not that long ago that was 17 that came to us, and she had perfect teeth, class 1 to 2 millimeter, whatever, overjet, maybe 30%, midlines were on. I mean, gorgeous smile, but asymmetrical face and jaw joint pain ever since braces, headaches, like pain and all that stuff. So they found their way through to our practice. And I felt so sorry for her because she showed pictures too. And you could see her face was more symmetrical prior to the treatment. And she knew it. She was aware of it. And really, in my opinion, her choices were you can go to all these providers who might do injections or do this or do that, but no one's going to fix the crookedness that happened in her face. And the crookedness in her face is reflective in the jaw and the jaw function. So ALF is a beautiful osteopathic unwinding appliance where we would try not to, mess up the smile that she accomplished. And she was also a class 2 before she started with braces. And so those heavy forces, you just don't know what the patient has been through from the beginning of their life till now with falls or birth trauma or things like that. And when you're pushing these heavy forces and every action has an equal and opposite reaction, sometimes kids will get scoliosis during braces, and then they take it off and usually it gets better, or they'll get facial scoliosis. And we see that so much, especially with the forward moving appliances.
It just makes me think too, sometimes, we don't know how patients are going to respond necessarily to an intervention that maybe one sibling tolerates it and is perfect. And then the other sibling, whoa, what just happened? Their nervous system changes or the, feeding function shifts. And it's something that I personally love about the ALF is because it is slower. We can adjust and we can slow down if needed, like if we see these changes.
Can I say something about that? Just because I think that that's a common perception that ALF is slow, but ALF is not always slow. Sometimes it goes really smoothly and you're finished in the same amount of time. But also what's most often not slow with ALF is other things are changing. Usually in the first month or two, long before you're starting to see the things that dentists are looking for, like the cheekbones are starting to pop. You can see more definition in the face and the patient just sort of comes into themselves, like their eyes are they're a little bit more present. And we start, having functional changes, significant changes, whether it's with sleep right away, because there's nervous system things. It's not always structure. You can have a tiny airway and it collapses and it stays open at night. And you can have a big airway that collapses at night. So it's not all about size and shape. And so even though people like to say ALF is slow, I have treated more than 500 ALF cases, and it's not always slow. And what's usually not slow is the beautiful things that I would never advertise for ALF, but the parents are coming in and saying, I can't believe it. Like, sometimes there's huge miracles that can happen in a short period of time. And then they're like, I don't even care what the teeth look like or how long it takes. Like, this has changed my child's life, or this has changed our family's life. And so those are the things you just don't see with the other appliances very often, if ever. So,
wow, absolutely. Let's take a moment to talk about one of my absolute favorite tools for supporting health and wellness at home, ozone therapy. You know I'm a huge fan of finding effective, science-backed ways to support our body's natural immune defense system. That's why I've been using the Stratus 3.0 ozone generator from Simply O3 for years. Whether it's tackling ear and sinus issues or boosting overall health, incorporating ozone therapy at home has made it so much easier for my family to overcome illnesses and proactively defend against sickness at school. As a busy mom and business owner, I love that I can support my immune health without needing to run to a clinic. And let's be honest, most of the time, when my kids get sick, it tends to be at night when clinics are closed anyways. Simply O3 makes it incredibly accessible to bring the power of ozone therapy into your home. Their equipment is easy to use and designed with safety in mind. And because you're part of the MyoHacker community, Simply O3 is offering 10% off your purchase when you use the code MyoHacker. Just head on over to simplyO3.com to check out their ozone generators and supplies and use the code MyoHacker at checkout. This question was submitted by another provider and I love it. So she said, we hear so often the way the ALF works is just by attracting the tongue to the palate. What deeper explanation can you provide as to how the ALF results in real skeletal changes? People have asked how that's different from just doing myofunctional therapy because myo is working on tongue posture habituation.
Okay. So first of all, the ALF is a team approach. Or it should be. And, I'll say that. And there are some patients that never have myofunctional therapy and still have beautiful results with the ALF. And there are some patients who never have body work and still have beautiful results with the ALF. There are some patients have just the ALF and nothing else, and it's amazing. And there are some patients that nothing is going to happen if they don't have one or both of those services. And it's harder, especially for new ALF providers, to predict which one of those are going to be the case. So my approach is always to say, I need to know that you're on board for a team approach. And we don't only include myo and body, like we talk about, potential for mold or pelvic floor PT or, whatever else. We want the whole child to be involved in this treatment and the results, so to speak. So in a perfect world, I also tell parents, you just should have body work and myofunctional therapy. You don't need me. But we don't live in a perfect world. And you know this more than anybody. Like, how many of your patients come to see you and then go home and do exactly what you asked them to do with gusto? Like, right?
I don't even do that.
Yeah, exactly. So, the ALF, one of the things it does, the way it's designed and the resonance of the wire and the resonance of natural cranial motion together, as soon as you place the ALF, if it's designed well and seated well, it starts cranial motion like the tongue. So that's why we call it a biomimetic tongue. So already there is motion where there may not have been motion before, which affects lymphatics and the entire patient, right? So if you got a bunch of junk in the brain that's not draining, that's going to affect your focus and even a kid's, fog, whatever. So right away in placing the ALF, we're getting cranial motion and improved lymphatics, and it just feels good to be on like that. And yes, the tongue is curious. So it goes up to meet the ALF, and the ALF, though, after a very short time, usually just 15, 20 minutes, if that. But for some kids with a lot of sensory stuff, it might take a day or two to first get used to it. But I've had ALF for years. I changed my whole jaw and vision and all that. But after having it in, the tongue kind of forgets it's there. So it's curious and it goes up to it, but it feels like second skin. Unlike any other appliance, you almost forget it's there unless you get a little piece of food, stuck in it. So it's doing the job of the tongue a little bit, and the tongue is curious and goes up to meet it, and you just find your tongue does rest up against the ALF comfortably during treatment. So one of the reasons is that it's not why not just do myo, or it's just attracting the tongue to the roof of the mouth. So it is doing those things, but it's also supporting. So while you're doing myo with the patient, you're just going to find like, wow, with the ALF in, the tongue suction hold is better. They're able to do this faster, better. Like they're able to get through their myo stuff with much more ease and without thinking about it so much with the ALF present.
Absolutely. It makes my job so much easier.
Yeah.
Yes. So something else is, is it the heat of our swallow or the movement that is it activating the ALF? Like what exactly is happening from the standpoint of the wire against the palate? Is it against the teeth? If you could explain that a little bit more, what exactly?
Well, the ALF should be sitting at the gum and the tooth interface. So it should not ride up on the teeth. Occasionally, are you going to have a tooth and the way it is, like it go a little bit on it, or maybe when you're getting towards much later in the case and you actually want to tip a tooth a little bit, perhaps. But in general, to get the cranial changes and the benefits of the ALF, it should not be tipping teeth and it shouldn't be riding up on teeth, period.
I just wanted you to say that because something that people often will say is the ALF, that it's pressing against the teeth and it tips the teeth and it's contraindicated. And
if
they're right there.
The teeth, the provider's gotten off track. For me, if I have a patient, and I'm not going to say I've never had a patient with tipped teeth, but let's say, for example, I'm working on a patient and I see now the E's are out of the arch. Mm-hmm. I've either moved too fast for the patient and activated too aggressively. The patient doesn't have the resources to make the changes in the time frame that I'm asking them to, like from a physiological standpoint. Or there's a lot of different reasons it can happen, but it's a sign for me that I need to back off. I need to bring everything back because our occlusion affects our dopamine. It affects so many different things with our nervous system that when you start like having teeth tipping and the bite not fitting together properly, you can have a patient that's in worse shape than they were. And that goes for palate expanders and everything else too. Like that's very hard on a patient to not have a solid, reliable bite, basically.
Quick question there. So a patient, actually not a patient, someone reached out just out of desperation. And she just wanted to know, she was like, I have reached out to so many people because my bite is off. And she was like, I feel crazy. Like I truly feel like I'm losing myself and losing my mind. And a lot was going on. And she said that she had reached out to providers, but their feedback was, well, your teeth shouldn't be touching each other at rest. Like you should just be chewing and your teeth are contacting. Then you shouldn't need to be grounding and feeling your body through your bite. Can you speak to that?
Well, true. Your teeth, you shouldn't be, for people who are clenching their teeth together, they probably have craniocervical instability or some other kind of issue going on. And they're bracing. But whether you're doing that or not, when your teeth come together, they need to come together in harmony. So, okay, as a dentist, you can tell a patient, well, you shouldn't be closing your teeth together all the time. You shouldn't be grounding through your teeth. But we know there's a lot of research out there about the occlusion and mental health and just plain nervous system function. So we cannot expect a patient to bite down and not be able to find their bite and not be able to find some sort of solid bite to not have some kind of, and again, we talk about buckets, like some people have a huge bucket. That's why we can do things to kids like palate expanders and TADs and all these crazy things. The kids that are going to be fine are the ones that have a huge bucket and it's not too full. But when you get that kid that their bucket's really small or they have a big bucket, but parents are divorcing and they just moved and they had this and their bucket's really full and it's that one thing that's going to send them over. So can patients get by with like a crazy bite for a little while? Many of them can, but those that tell you they can't, they can't. And we really need to be careful when we forget that it's connected, right? But we really need to be careful when we're in here and doing work. It's not like, oh, they'll be fine for 6 months with their teeth all like, not biting and everything. It affects their gait. It affects so much stuff. So yeah, I think that patient needs help. She's asking for help or he's asking for help and they deserve it,
Yes.
Yeah.
Yes. Another amazing question is, I don't even think it's not that deep, but it's very practical. So what is the average amount of time a child is in the ALF to achieve appropriate space? And maybe we can even say, is it space with the children you treat?
Yeah, that's a funny question. I remember, so I originally first trained under Jim Bronson, and I just have to say that was a great experience for me because I hated ortho, like totally. A lot of pedo hate ortho and appliances. And I went to a course or a lecture that he gave And it was a beautiful presentation. And I don't even remember what the teeth looked like. It wasn't the point, but I'm sure they looked pretty good before and after. But it was like this whole child's life was changed. And I was like, wow, that is so amazing. I saw him afterwards and I was like, I wish I could do that, but I don't bend wires. And he's like, oh, really? He literally pulled an ALF out of his pocket. And he was like, messing with it. Could you do this? And I'm like, oh, maybe I could. Like, that's not so bad. So I went to his course, which is a different teaching philosophy than Nordstrom and Tenholder and Terzo, which I've learned from all of them. But it helped me and it helps many to like get on the path with a dentist brain starting out in ALF. Okay. So after learning from Jim, and so we would make the treatment plans. We get a lot of help through his course, the level 1 course, which was a year. And that's your mindset. It's going to be 12 months to 18 months or 18 months to 24 months because we're dentists. And the public patients are used to having this like solid time frame and we're used to having it. So we'd be looking at our patients and going like, oh, I don't have this perfect smile in 18 months or whatever. And then talking to Dr. Terzo later and even Jim, it's like, look at all the things that have changed because we're looking at everything in those courses and residencies. Like, look at this kid. Like, he doesn't even look like the same child. Okay, so you still got a little crowding here. You got a little this or that there, but just stick with it. It looks phenomenal. And normally the parents aren't even I have parents that just don't ever want their kid out of ALF because they're like, oh, I want me. It's like, it's me. But, so having said that, I would say that the younger the patient, the faster. So maybe 12 months, maybe 18 months. The older the patient, typically longer. But again, it depends on what you're asking. So and most of the time for me, I would say that a lot of cases go around 2 years, but there are some that go 5 years. There are some that I finish and I like the way they look and the way they are, and they'll come back and say, I want my ALF back because they have tics or they have anxiety or they have these other things. And the child is like, I feel better with my ALF. Can I explain all of that 100%? No, I have thoughts on it. But so if you're asking about teeth, my goal with ALF when I'm doing a patient, and I tell this to parents, is that when we say we're done with this foundational phase 1, which is primarily what I do, no matter what age the patient is, it's this foundational phase 1. I want them to have their lips closed. I want them to be breathing through their nose most of the time, unless they're sick. I want to look at their posture from the side view and see that the jaw is over the shoulder, is over the hip, is over the knee, is over the ankle, because we know that all this little stuff that they do is airway, right? So when we can see their posture change from all the views, the shoulder tilts and head tilts and all those kind of things, we know they're breathing better and they're breathing through their nose. I want them to have a good swallow pattern so they've gone through the function and they can swallow properly. And I'd like for their jaws to be big enough to fit all of the teeth. And if they're going to continue growing with this good function, then their jaws are probably going to fit their wisdom teeth later. So for me, I don't care if there's still a little crowding here or if the cuspid came in ectopic here or there's a rotation here. They can safely go have a phase 2 to level and align the teeth later. And the orthodontists that I work with, I love because they'll, when they're talking to patients who are considering, should I do a phase 1 expander or phase 1 ALF? Or when they come in to do the phase 2, they're like, we love working with Dr. Amy because the patients are so easy. Like the finishing is so easy. We're not working against a lateral tongue thrust and say, where are your rubber bands? Or, all these other things. And so they get not only this beautiful face and great posture and breathing well and swallowing well, but then they can finish with the leveling and aligning. So, to get to that, it's usually not more than 18 months or 2 years that we'll stay in it sometimes because we can continue to change and shift, but ALF is not meant to level and align teeth. Most providers who finish that way are doing some phase 2 with either segmental trays, similar to Invisalign, but made in such a way that they don't lock the cranium, or some light wires to just rotate and level and align the teeth.
So beautiful, guys. I love talking about this. And I just think it's such a different way of approaching the body and just as a whole, because you are thinking of how things are affecting just the feet and the hips. And like you said, the whole body. So do you ever feel like the ALF is contraindicated? Like there are times or children that you see that are so severely underdeveloped that you feel like the ALF may not be able to achieve results that they need?
I don't think the ALF is contraindicated. I had one girl who was severely allergic, and within 24 hours, she had like all this pus and stuff. So I sent her to a NAEP provider, and he actually did allergy elimination, and she went stayed in ALF. So that might be an indication if you have a child with something, like physiologically going on in that way. For me, when you ask that question, Karindy, even really what the question is really asking is the ALF enough, or do you need the big heavy stuff to come in on some kids because they're so far gone? But the question still always comes to me first, why are they that way? And oftentimes, in the ones that have the teeny tiny mouths and are really underdeveloped, their whole head is messed up. I had a little girl who came to me when she was probably 2, and she was a second opinion for a glossectomy, or something to cut parts of her tongue off, because basically the medical community, her tongue was hanging out all the time, and they're like, her tongue is too big. They were doing genetic testing and things like that. And so the first thing I started with her age, because I wasn't doing that young of ALF at that time, was I sent her to an osteopath with about 40 years experience. And he sent me an email back and said, there's nothing wrong with the size of her tongue. Her oral cavity doesn't have enough volume because her head shape is ridiculous. And she had pretty hair, and but she looked a little bit funny. So all she had was osteopathic work. And by age 3, her tongue was in her mouth. Her head shape was better. It is all connected, especially with the head and the mouth. And if you have this weird head shape, from previous plagioccephaly or whatever else, it all has to be addressed together. So I'm asking, why is the oral volume so tiny in this patient's mouth? And I think they need ALF before and that's what I think about most anybody. It's safer to do ALF first, because one of the things we haven't talked about is with that motion that the ALF is creating and that resonance, you're getting fascial unwinding starting at the cranium, which kids don't really need chiropractors cracking the back, especially little bitty ones, because they develop from the cranium down, which is what Tasha teaches in her book. And so when we got things going down somatically, it starts up here. And it can be birth trauma, or being in one position for a long time, or they fell down and on their head and they looked okay, but things happen. And so putting that ALF in and creating that motion and getting the fascial unwinding starting is okay, then if you absolutely have to, you've got a syndromic kid or things like that, and you need to go into other appliances later, there's going to be less of the increased asymmetry of the body or the face or the head, and you're going to have that unwinding. And I've had some really severe tiny mouths. In fact, I just had a kid who finally got a genetic finding, which was a rare genetic thing. And the neurologist said to her, she's been in ALF for about a year, and she was anterior crossbite, posterior crossbite, tiny mouth, funny little, stuff going on, but no diagnosis other than I think she had seizures or something. But the neurologist said, oh, this is the diagnosis, and it comes with cranial abnormalities and micro this or that. And he looked at the girl and he goes, I'm not really seeing that in her case. And Mom was telling me, we went, and I said, take a picture of these pictures and go back to him next time and show where she started. And Nordstrom shows pictures of doing amazing things with cleft palate patients. I've had some cleft palate patients that have had much better outcomes. So no, I don't think the ALF is contraindicated. And I think everybody, if they could, in a perfect world, would have ALF for a little while before they even consider, heavy crossbody appliances, cross midline appliances. But that's just my bias.
Which is why it's so wonderful you are now consulting. So if you guys are listening and you're like, I want an ALF provider who is looking at this whole body approach, who is, facilitating fascial unwinding of the cranium and the whole body, but there's no one around me, send this episode to your dentist. Let them know that actually there's an amazing provider, Amy Luedemann. She is able to provide this consultation with dentists who are seeking this ALF training, and really it can be so much. Amy's mentioned she's had so much training. She has really seen a lot of different perspectives on how to implement and utilize and adjust the ALF, all of these things. So I highly recommend just providing her information as a resource, and I will link to that, all of that in the show notes. Amy, what is a great way that people can reach out to connect with you?
Yeah, and I just want to add to that, Karindy. Mm-hmm. I kind of think of myself as your training wheels. Mm-hmm. So I love it when people start with Tasha's course, her online course, just because so many dentists know nothing about osteopathy, and she's worked with Nordstrom for decades. So starting with something like that, but if they've had 1 or 2 ALF courses, like I did, and you come home and you're like, but what do I do here? What do I do here? That's where I love to come in and help you get going on some cases, and also to help you to know who's your next teacher based on where you're going and because I've learned from Nordstrom and Bronson and Terzo and Tenholder. And so I can, and yeah, so that's kind of, I'm there to help, but I'm not the only person. And sometimes people have a hard time learning from Nordstrom, for example, without having a little bit more help before they're able to like grasp his deep brilliance. So my email address for the consulting is dramy@integratedsmile.com. And I really haven't made a website or anything because I'm not doing a ton. Like my first opening is in March right now. Yeah, because I'm doing other stuff too. So I would love to help anybody because I'm very passionate about making more ALF providers available for patients. But, it won't be that long that you'd be working with me. And then, you're able to go to some of those other courses and get a lot of good information.
Amazing. All right. I will link to that. And Tasha Terzo's course and book are amazing resources that people can go to right now and just jump into that right away. And her book is called The ALF Approach. And then do you remember the name of her course?
I think it's ALF Approach as well, or it's
Perfect.
If you go to the ALF Approach website, she has her courses. She also has a mentorship program. I'm one of the faculty on it. So you can go and present cases. You can ask questions. You can listen in because there's osteopaths, dentists, myofunctional therapists. So we had some cool ENTs from Singapore on there once. And so it's a nice collaborative international community. And it's a great way if you're providing ALF to get some feedback and support. I think what's great about what I'm able to do now is I can come to your office and like literally help you with your appliances and your patients so that it's right there and you feel good about seating them and adjusting them and things like that.
Amazing. Well, thank you so much for your time and for coming and for chatting with us today. And we'll have to have you back on to talk about some of your biohacking endeavors in the future. I hope you have enjoyed this episode of the MyoHacker Podcast. Remember, small changes can make big impacts on our overall health and well-being. If you enjoyed this episode, please take a moment to rate and review wherever you get your podcasts. This way, more families will learn about this important information and we can make a bigger impact. Head on over to myohackerslp.com for in-depth resources and guides. You can also join me on Instagram at myohackerslp for bonus content and demos. And if you have questions or topic suggestions for future episodes, send me a message. I would love to hear from you. Until next time, let's biohack myofunctional health as myohackers who change the world through intentional action and connection and breathing. Quick disclaimer reminder, the content shared in this podcast is for informational and entertainment purposes only.